Good morning, everyone. Welcome to our rounds today. It's a great pleasure to introduce Dr. Ferdinand. Dr. Ferdinand is a professor of medicine and the Gerald Garrison Endowed Chair, Preventive Cardiology at Tulane. He received his medical degree from Howard University, and he's a fellow of the American College of Cardiology, American Heart Association, American Society of Preventive Cardiology, National Lipid Association, and an honorary fellow of the Preventive Cardiovascular Risk Association. He's the past chair of the National Forum for Heart Diseases and Stroke Prevention, and he serves as a chief science officer and past chair of the Association of Black Cardiology. Dr. Ferdinand has conducted numerous trials in hypertension. He has over 350 publications. He's a consultant for also the important companies that develop the pharmacologic therapy that we use every day. And, he's an expert not only in hypertension, but in lipid metabolic risk, in all the areas of preventive cardiology. He is certainly one of the leaders in the field, and I think this is going to be one of the best run rounds that we experienced. It's a great honor to have you here.
Oh, thank you, Mario. Well, I'm very pleased to be here. Actually, there's a lot of ties with your institution in Tulane. Jose Wiley walked me called, and I think there's a person who's going to be a fellow with us, Juan, here. Yeah. So I'm going to talk about the guidelines. I'm vice chair of the new 2025 high blood pressure guideline, but I'm not going to just do a remote mechanical going through the guidelines. I'm actually going to give you some insight as to what's new, but then I'm going to address health equity. You know, in the political sphere, you hear people say that you don't have to be worried about diversity and equity. Well, that's wrong. I think I'll show you data that it's both a moral imperative, but it's a practical imperative. We waste dollars. We don't target people who need it the most. So let's see if this is going to work. Get all the glitches out. Here are my disclosures. First, I'll talk about the guideline. I'll look at some of the key rationales for both lifestyle and medication. We're the first major guideline to use the Prevent Risk Calculator. That's the one that was promulgated by the American Heart Association. There may be cholesterol guidelines coming out soon, and they may use Prevent also. So you'll get a chance, if you go to our guidelines, to actually utilize Prevent. And then I'll show you the algorithms to work your way through hypertension, both in terms of initiating medicines, secondary hypertension, severe hypertension, and resistant hypertension. Here's the faceplate for the guideline. You note the two major associations, American Heart Association, American College of Cardiology, a member of both, but then there's a whole alphabet soup of different medical associations that are part of the guideline. Now, why is this important? I'm a clinical cardiologist, but I trained at a time where I did everything. I did pacemakers, skin-to-skin, pulmonaries, peripherals. I did my own angioplasties in the 1980s. Brunswick was 81, 82. I did one in 84. But now I recognize that if we want to change the curve on cardiovascular disease, yes, you have to learn those things. But it's more important just than doing interventions and mopping the flow. We need to turn off the faucet. And if we don't address prevention, then we really won't make a difference. But that individual patient is very important. Acute coronary syndrome, the person who's in the throes of cardiogenic shock. But for the public health, we have to address these modifiable risk factors, and blood pressure is the most prevalent of all the risk factors globally. It also builds on the platform of what American Heart Association calls Essential 8. Those are the things that if we do right, we might be able to prevent disease before it manifests itself. And it builds into the concept that it's not just blood pressure in a vacuum. There's now something called cardiovascular kidney metabolic syndrome. I'm not going to go into all of the aspects. I'm going to focus on blood pressure, but I do recognize it's not in a vacuum. This is an important diagram. It comes from the Blood Pressure Trialist Collaboration. Over 344,000 patients, over 48 randomized clinical trials. You see the direct linear relationship between lowering blood pressure and decreasing cardiovascular events. This is the landmark SPRINT trial. It informed the last guideline in 2018. New guideline came out in 2025. So these guidelines take time. We have scientific statements and position papers, but the entire guideline with all of the various committees coming together usually takes 4 to 5 years. And we built in some new studies out of China, STEP, older persons. We now think that age is not a limitation in intensive blood pressure reduction. ESPRIT, high risk, including patients with diabetes. This idea that persons with diabetes don't intensively benefit from blood pressure reduction is no longer considered correct. BP Road, patients with diabetes. And a new trial, the China Rural Hypertension Control Study. This was a study that showed conclusively that lowering blood pressure not only decreases cardiovascular disease, but it also decreases dementia and cognitive dysfunction. That's new in the guideline. So when you look at that linear direct line of lowering cardiovascular events, it's for people who have what we previously called normal or high normal, patients who have high risk, who have previous cardiovascular disease with or without diabetes. So here's the take-home messages. I'll give you, throughout my talk, some take-home messages, things that you should remember when you approach the guidelines. High blood pressure is the most prevalent modifiable risk factor. If you look across the various things that, oh, I got the internet. If you look at the various things that it affects both coronary disease, heart failure, atrial fibrillation, stroke, dementia, that's new, chronic kidney disease, and all-cause mortality. Dirty secret, those of you who are new physicians, if you've only been a doctor for the last 4 or 5 years, don't tell the public, but you should know there's not much we do that decreases all-cause mortality. Treating blood pressure intensively is one of those things. The overarching goal is less than 130/80, but note at the bottom, you recognize if a person is living in an institution, has limited life expectancy or pregnancy, that may not be for them. This is a bar diagram. The citation is from American Heart Association Heart Facts and Statistics. And I suggest every year in January, you look for this document. It's very thick. It's very comprehensive. It looks across all of the various cardiometabolic conditions from the American Heart Association. This is their latest one, published in January of this year. And you see in terms of awareness is actually quite high across all populations, even the non-Hispanic Black population, which has a high burden of hypertension, cardiovascular morbidity, and mortality. They're aware. Even treatment is high. When we fall down across populations with disparate levels of control, that's what's the problem. So it's how to control blood pressure more than just measuring the blood pressure. This is directly out of the guideline. You know this, but there's a nuance here that you may not see, and that is we now define blood pressure as 130/80. Okay, you have that. That was in the old guideline. But if you look at the bottom, 1/8 and or 120, you see severe hypertension. What you don't see is hypertension emergency urgency. We say emergency if the person has target organ damage, and we took urgency out. There's no urgency. It's only the emergency. So I will show you what that means later when we get to the guideline itself. Another thing we suggested in the guideline is that you should use urine albumin creatinine ratio. We used to call it microalbuminuria. It's a marker for CKD even before the GFR is decreased less than 60. And because the glomerulus is simply a tuft of arterioles, it's a marker for cardiovascular disease. So this is something you should do in all of your patients, even if the GFR is over 60. And we suggest you use the CKD epi creatinine equation for GFR. That's new. That's the one that removed black race because it used to give more points in terms of GFR for black race, and had the unintended consequence of those patients not being referred to nephrology and not being referred for kidney replacement. All right, what about out-of-office home blood pressure monitoring? I think this is very important, and I'll show you some work that we do in New Orleans in this arena. We give a class 1. If the person has hypertension, they should measure their blood pressure out of the office. We do a really bad job in the office of measuring blood pressure appropriately, and use either an ambulatory blood pressure monitor or home blood pressure to confirm the diagnosis. Also, once you make the diagnosis, out-of-office blood pressure helps us monitor the patients when you want to titrate medicines. It has education. It helps with telehealth, and limited in terms of clinical interventions. You really don't know what to do based on that 15-minute visit that we see in the clinic. No benefit. The American Heart Association has a scientific statement that came out in December. This is from the guideline. Class 3, harm, don't do it. It ain't right. Cuffless blood pressure devices. And we can discuss those in questions and answers. We know there's a watch now that's being marketed for blood pressure. We gave it a class 3. All right, let me make a few comments on disparities, and I'm going to end on disparities before I go more into the guideline. The reason I think it's so important is that in our great country, we spend more per capita on healthcare than other developed societies. But if you look at life expectancy, it's the shortest. Western Europe and Japan have longer life expectancy. But that's not just because living in the United States leads to shortened life expectancy. If you have insurance, if you have means, if you live in a stable social environment, if you know how to navigate our very tortuous, difficult to navigate healthcare system, you live just as well in the United States as you do in Western Europe and Japan. The reason we spend so much money is because of these disparities. When do the patients go to the hospital? When they're sick, when they can't urinate, end-stage renal disease could have been prevented. When they can't see or they can't move a body part, stroke or TIA could have been prevented. When they're having chest pain, an acute coronary syndrome could have been prevented. When the toe turns black, severe peripheral arterial disease. At that point, the cost of care is much higher and the outcomes are much worse. So the idea that we shouldn't spend time on equity and trying to get the people who are most disadvantaged doesn't make good sense. Morally, I don't think it's right, but practically, it's not right. This is a picture of a hospital, and the first author is Gladys Villard. She's from University of Florida. I was part of this working group, and we made this concept that if you look at registries in hospital care, it's pretty good in the United States, and you don't see the same types of disparities that you see as outpatient. But what happens is the patients return from their inpatient facility. If I can go back. Well, I didn't show it, but if you remember, it showed that circle. If they go out into their disadvantaged social determinants, then they return to the hospital. So if you don't address that, you don't address those disparities. These are data from New York. I'm not from New York, but I just looked it up. And it shows across people who self-identify from certain areas, and especially those born outside the United States, tend to have higher prevalence of higher blood pressure. A lot in the Dominican Republic, patients who were originally from there, much less than so in the Mexican or Americans. We're not really sure why. It may be related to admixture of African ancestry, but there are differences across populations. And we know in terms of having access to medical care, there are differences across populations. Remember, you don't waste dollars when you give people access to care. You save dollars because you stop the person from showing up with end-stage disease. This is a map of the Bronx. Historically, they would actually grade certain areas, and they would give a grade D for those areas. This is from the government, 1935. They would give those areas which had a higher rate of Black populations, a higher rate of people who had adverse social determinants, and they would say those were undesirable areas to give loans for home and businesses. And the legacy of that is that when you look across cardiovascular disease, hypertension, heart disease, and stroke, you still see these great disparities. So that's called the social determinants of health. Another term is social drivers of health, where you work, live, play, and pray has a profound effect on your burden of cardiovascular disease in life itself. This is also, in preparation for this, I looked for New York, and I specifically looked for the Bronx. And these data suggested that you have higher rates of high blood pressure in certain populations in the Bronx, that there are structural inequities. And I'm not talking about social science. I'm talking about real structural inequities that affect socioeconomic and environmental conditions that influences health. And unfortunately, this is a wonderful hospital. You have a great reputation, but the Bronx overall ranks last in health outcomes across 62 counties of New York State. So let's go back to the guidelines. I set the table why I think health equity is important. It saves lives, but it also saves dollars. But let's look at the guidelines and see what they say. First of all, while we say less than 130/80, we encourage less than 120. Lower is better. And it's somewhat counterintuitive. People who have orthostatic hypotension, especially if they have hypertension, the blood pressure swinging around, the baroreceptor is affected, they actually do better if you control blood pressure. Those episodes of hypotension actually start to ameliorate. This is the prevent risk calculator. In the yellow, you can see it looks like the conventional risk factors, but it adds the social determinants of health. You can actually plug that into the risk calculator. Now, you don't have to, because the other conventional risk factors still are very, very powerful predictors, especially age. Do the A1C. They say when indicated, that's especially persons who have diabetes, prediabetes, or overweight status. And the urine albumin creatinine ratio. This is the prevent risk calculator. It says when indicated, but in the guideline, the way we say it is in everyone. So it's not just when indicated. And this is for primary prevention. Now, if a person has cardiovascular disease already, which almost all of your patients will, you don't necessarily need to do a prevent risk calculator. And I'll show you the algorithm on how to use that. It's available online. You can download it, do it on yourself, do it on your loved ones, and get an idea of how to use this tool. All right, here's the example. Here's a young guy, 35 years of age. So he doesn't have age as a risk. The lipids are not terrible. HDL is a little low, but it's within normal limits. Blood pressure stage 1, 136. Weigh the person, get a BMI. GFR is good. Ask about medications. Always do urine albumin creatinine ratio. You didn't have to do an A1C since the person didn't have obesity or prediabetes. You didn't have to do the zip code. It may add a nuance to your risk calculation. But this person is low risk. We use high risk for 7.5% or greater. So this is a low risk person. What should you do? What does the algorithm say? This is directly from the guideline. Is the patient 140/90? No. Remember, the systolic was 136. Does the patient have existing cardiovascular disease? No, he didn't. Now calculate risk or ask if the patient has diabetes or CKD. And CKD is a GFR less than 60, but it also is a urine albumin creatinine ratio of 30 or above. The answer is no. If that's the case, you don't have to start medicines immediately. You can give 3 to 6 months of lifestyle. And I'll talk about what type of lifestyle we recommend in the guideline. On the other hand, if the person's 140/90, we now say start medications immediately. Continue lifestyle, but start medications immediately. If the person has clinical cardiovascular disease, initiate medications immediately. If the patient has diabetes, CKD, or if you do the risk calculator and it's 7.5% or greater, initiate medication. So first, 140/90, treat. 2 drugs, low dose combination. Cardiovascular disease, treat. Diabetes, CKD, or prevent risk calculator, 7.5%, treat. The take-home message. Adults who have stage 2 hypertension, average 140/90 or above, 2 first-line agents, different classes, single pill, fixed dose combinations. Why? It improves adherence. It also will increase blood pressure control, and you'll get there quicker and more effective. Take-home message, 140/90, 2 pills, 130/80. Consider lifestyle if they're low risk, but if they have clinical cardiovascular disease, treat. Medications are good. Everyone in this room, except a few of you, know about the VA cooperative studies from the 1960s, where they had veteran men who had systolic blood pressures averaging about 160. And they did what's called a placebo-controlled trial. Half of them, they put on medicine. Half of them, they just said, take a sugar pill. After 2 years, the people in placebo, half of them had heart attacks, strokes, or were dead. So I tell my patients, I don't want you in a placebo-controlled trial. I want you to have the benefits of medicine. And we know people say they don't want to take medicines, but you need to understand and believe and transmit to your patients the idea that medicines can be life-saving for cardiovascular disease and overall mortality. This is new in the guidelines. Intensive blood pressure control not only affects cardiovascular disease, but can reduce the risk of dementia by 12 to 19%. That's a powerful message because I think it will help us as clinicians convince our patients to take their medicines, but it also will convince us as clinicians to prescribe the medications. Nobody wants to be demented or have cognitive dysfunction. This is the Chinese Rural Hypertension Control Study. Look at the sample size, huge, over 33,000 persons, treating the blood pressure intensively. Somebody has to come back and get these slides up. Treating the blood pressure intensively not only lowered cardiovascular disease, but lowered the risk of dementia. So that's in the guidelines. It's a big component of the guidelines, and it's one of the things you should utilize to help your patients understand the need to control blood pressure. This is the evidence, 1A, intensive blood pressure reduction reduces cognitive dysfunction and dementia. All right, what about lifestyle? The lifestyle, I think most of you know, maintain or achieve healthy weight. The DASH eating plan is the best evidence for that. Increasing dietary potassium, and I'll show you a study again out of China, where they added a potassium-rich sodium-potassium combination. Manage stress. We're going through the lifestyle now. We started with weight, then we went to the DASH diet. I mentioned I'm going to show you some data on dietary potassium and its benefit in terms of blood pressure. And I'm going to talk about stress and alcohol. I will tell you there was a big debate with both stress and alcohol. We said that abstinence is best. And I remember we were having discussions in the committee, and I said, well, I'm from New Orleans. People are not going to abstain completely. So we went back to abstinence is best, but if they cannot abstain, it's 1 or less for women, 2 or less for men for alcohol. Alcohol has a blood pressure elevating effect. For stress and reduction, we gave a 2B. 2B means that you may want to consider meditation and yoga. There's some short-term studies that have shown that meditation helps with blood pressure control, but it's not a class 1A evidence. Are they up now?
Yes, it should be. If you click in there, it should change.
It's okay?
Yeah, if you click in the slides, it should.
This is the cell substitution trial out of China. Again, they do these large trials, big population, over 20,000 persons, half of whom were female, 3/4 of whom had previous stroke, 88% with hypertension. And they showed by adding a mixture of 75% sodium chloride, 25% potassium chloride, using that in their meal preparation, they decreased stroke, cardiovascular events, all-cause mortality, and did not really show an increase in hyperkalemia. So here are the lifestyles directly out of the guideline. Class 1, weight reduction. We do mention the GLP-1s. We recognize the barriers of cost and access. Diet. The DASH diet is superior, class 1. Low sodium intake, less than 2.3. Ideally, though, less than 1.5 grams. The salt substitute is a 2A. You may want to consider, and that's going to be for patients who prepare food from home. The person's doing a takeout food, adding a salt substitute is not going to help blood pressure reduction because you already have the sodium in the food. Moderate potassium intake, that would be fresh fruits and vegetables. That's going to be a class 1. Alcohol, 1 or less for women, 2 or less for men. Abstinence is best, but remember that debate that I said we had. Abstinence is best, but realistically, for persons going to consume alcohol, those are the guidelines. Aerobic activity with resistance activity, 2B, consider stress reduction. And using these lifestyle and psychological approaches, we think is the bedrock of condition. This is not from the guidelines. This is a cartoon from NIH. And I included for a real reason. I had a gentleman in my clinic, and I asked him how much he drank. He says, I only drink two at night. You know, give me a couple of drinks. When I asked him what it was a double shot of Hennessy. So always ask the person, what do they mean by a drink? So it's going to be a 12 ounces of beer, 5 ounces of wine, 1.5. If that guy is drinking a double, he's already done his 2 drinks. Now, why do we say give medications after 3 to 6 months? Well, first of all, we do recognize there are limited data that you need to start those patients immediately on medicines. I understand that. And we should encourage lifestyles in all patients. But it may not be successful. It is hard to change a person's eating pattern, exercise pattern, lose weight. And it's difficult to sustain at optimal levels, even if the person is initially successful. Therefore, we suggest 3 to 6 months, initiate antihypertensive therapy as an adjunct to lifestyle intervention. All right, let's go to medications. Remember, medicines aren't bad. Forget what you see on the internet, Instagram, and TikTok about how terrible medicines are and how bad we are as physicians. They are life-saving. They decrease cardiovascular events and improve total mortality. We have evidence-based medicine for that. The medicines that we recognize as the main components first are diuretics. Thiazide type, that's hydrochlorothiazide, one called indapamide, another chlorthalidone, loop diuretics. The person has significant decrease in GFR less than 30. Calcium blockers, which ones? We think the data are strongest for long-acting dihydropyridines, amlodipine or extended release nifedipine. ACE inhibitors, ARBs, we give equal weight to. ACE inhibitors may have more data with FREF, may have more data post-MI, but for blood pressure reduction, they seem to be very equal. Remember, ACE inhibitors will also give you, at times, a disabling cough in about 10% of people, and there may be higher rates of angioedema, especially in people of African ancestry. Mineral corticoid receptor antagonists, that's spironolactone or epirlinone, are then going to be added. Spironolactone has the problem of also stimulating estrogen receptors, so it causes breast tenderness, gynecomastia, especially middle-aged men. They may do better with epirlinone, but there's a cost, even though it's generic. Here's the class 1A for the recommended drugs, the thiazide types. We use that term of art because it's not just hydrochlorothiazide. Long-acting dihydropyridines, ACE or ARBs. All right, what about special conditions? Patients with CKD, and remember, we define CKD as a GFR less than 60 or albuminuria. You're doing a urine albumin creatinine ratio on everyone. So even if the GFR is over 60, if they're spilling small amounts of protein, they have CKD. The goal is less than 130 to decrease all-cause mortality. If the patient then has CKD and hypertension, use either an ACE or an ARB, not both together, to decrease cardiovascular disease and delay the progression of kidney disease. What about diabetes? These are all class 1A recommendations. Less than 130, cardiovascular morbidity and mortality. All of the agents seem to be effective for persons with diabetes. You don't see beta blockers. We don't include beta blockers as the first step because for hypertension alone, they don't seem to have as much protection against stroke, especially in older persons. So we don't have that as a first step. But you have the thiazide type, long-acting CCB, ACE or ARB. And then if the person has albuminuria, definitely an ACE or an ARB because you have more data in persons with CKD diabetes. What about obesity? Very difficult for patients to do it by lifestyle alone. If they can have access to GLP-1s, is given 2B, you may want to consider. And bariatric surgery, if the BMI is 35 or greater, along with behavioral interventions, 2B, you may want to consider. All right, let's move over to secondary hypertension. Secondary hypertension means the person has elevated blood pressure. It is not primary. There's something that the patient has or something they are doing or something they are taking that's causing the hypertension. That's secondary hypertension. Across the top, you see the common causes. Primary aldosteronism, obstructive sleep apnea, CKD, alcohol again. And you see some of the things that we recommend. First, we say screen. In the interest of time, I'm not going to read all of these, but I'll just point out a few. Patients you're treating, they're taking the medicines, and it's not working. They may have secondary hypertension. Abrupt onset, hypertension before the age of 30, disproportionate target organ damage. The CKD, the LVH is just out of what you would expect in a young person. Diastolic hypertension in an older person. As we get older, the vessels get stiffer, the systolic pressure runs through, reflects back, systolic goes up, but the runoff is quick. The diastolic goes down. So isolated systolic hypertension is the main phenotype in an older person. If you see diastolic hypertension, think something's going on. Excessive hypokalemia, insomnia, maybe sleep apnea. All of those are things. And if you see a person with secondary hypertension, then consider primary aldosterone. I should also say obstructive sleep apnea. And you may be able to treat the person by approaching those conditions. In terms of secondary hypertension, also remember, we said abstinence is best. Patients who consume large amounts of alcohol, you can have a blood pressure lowering effect by similar effects in that. Forget clonidine, it's the devil. We use it in the emergency room and urgent cares to cosmetically lower the blood pressure so that we can send them home. But its half-life is only 3 to 4 hours. If they don't have their medications, if they have poor health-seeking behavior, if they have poor medication adherence, it's going to be back the time they're settled down for their evening dreams at night. And tizanidine, which is used again for muscle relaxant, also has reflex hypertension. In a young woman, think about the contraceptives. Use lower doses, and there's now a progestin-only contraceptive. These are data that were just published this year, and it looked back over the last several years, a national sample of over 1,800,000 persons. And you can see a higher degree of them were identified as Black, about 50% female. And what you see in those Black patients, that persistent gap. And it's quite distressing because time does not always equal progress. We're still seeing patients who come in with hypertensive crises and increased mortality. And it's just not necessary for a condition where we have so many great treatments. All right, so that's secondary hypertension. Let's move now to resistant hypertension. What is that? Persons on 3 or more antihypertensive drugs. They're using the classes that we suggested, diuretic, long-acting calcium blocker, ACE or ARB, so they're doing the right thing. But they still have a blood pressure greater than 130/80. Forget about treating them for resistant hypertension if you're not doing it right. So that's called pseudo-resistance. Forget about resistant hypertension if they're drinking too much alcohol or they're taking some over-the-counter medication, a stimulant. That's not resistant hypertension, that's pseudo-resistant. And remember white coat hypertension. We used to think patients were crazy. They would tell us, blood pressure is only high when I'm here. But we now know using ambulatory blood pressure monitoring and out-of-office blood pressure monitoring, about 15% of patients really only have elevated blood pressure in the clinical setting. So that's not true resistant hypertension. And that's one of the reasons we suggest everyone measure blood pressure out of the office setting. And then screen for those underlying causes that we just discussed. Resistant hypertension is bad. It's anywhere from 8.5 to 20% of the population. It goes up with age, obesity, CKD, diabetes. It's more common in Black populations and patients who have those adverse social determinants. So again, the social determinants of health, this is not social science. It has a real impact on patients' health outcomes. And if the person has true resistant hypertension, they have 50% higher risk of MI, stroke, end-stage renal disease, and cardiovascular death. All right, here's the algorithm for resistant hypertension. Use the 3 classes. I've described those to you. Exclude pseudo-resistance. Identify contributing factors. Remember NSAIDs, true licorice, and stimulants can do it. Screen for secondary hypertension with aldosterone and activity level. And then consider replacing the hydrochlorothiazide with chlorthalidone or indapamide. Indapamide is available generic. It's been used in many of the European studies. It has great outcome. It comes at 1.25 and 2.5. Chlorthalidone is 25 milligrams, and it tends to be more effective than hydrochlorothiazide. And there's another potassium-sparing diuretic, which also is effective with resistant hypertension, called epinephrine. Chlorthalidone also has benefit and loop diuretics, CKD 4 or 5. There's another drug called aprocitentan. It's listed in the guidelines, along with other vasodilators. Aprocitentan is an endothelin receptor antagonist, and it was approved by the FDA in November of 2023. The uptake has been real slow. but it also appears to be beneficial to resistant hypertension. All right, remember we showed the blood pressure and I said this is new and many of you are really paying attention when I said it. I'm going to focus on that again. We removed the concept of hypertension urgency, that 120 over 180, 180 over 120. That's called severe hypertension. But if they don't have target organ damage, we don't call it urgent, and they should not have aggressive blood pressure short-term lowering. So the orders that we use in the hospital for parenteral hydralazine, oral clonidine, should not be utilized if the person doesn't have acute target organ damage. And we give a class 3 if the person has 180 over 120, not having acute cardiovascular disease, and they're hospitalized for non-cardiac conditions. Those standing orders that we use for intermittent use of additional parenteral medicines or oral clonidine is not recommended. Now you're going upstream because everybody does it. The data really is not beneficial. Many of those patients actually have side effects. They can develop hypotension, coronary insufficiency, acute renal failure. Sometimes it's simply pain or not having their home medications available. That's called severe hypertension, but there is no hypertension urgency. That's new in the guidelines. All right, let's look at severe hypertension and hypertension emergency. 180 over 120, acute target organ damage, yes, and that's a true emergency. Those are the patients who are admitted to the intensive care unit with acute aortic dissection, pheochromal. But if the person is no, even if you identify them in the emergency setting, just put them back on their medicines in the dark blue, avoid parenteral medications or intensive oral therapy. And there's no need, if you see them in an outpatient clinic, to refer them to the ED. Just reinstitute their medicines or intensify or modify, educate, motivate, but that patient does not need to be admitted. I'm going to spend the last 5 to 10 minutes, and we'll have some time for Q&A. We had some technical difficulties on the front end, but I'm going to move quickly because I think this is important. Eliminating disparities is still a very component of what we need to do for the public health. I was asked by Nature Cardiology to give my comments on the case for eliminating disparities. I wrote this in 2024. It really is even more an imperative now because there's some people who push back against this whole idea of targeting certain populations. And what I said then, and I'm going to stick by it, is that overcoming these conditions is both a moral and practical imperative because it leads to short life expectancy, it leads to worse outcomes, and increased healthcare costs. What we need to do is actually reduce disparities. Giving universal health insurance is not communism. It's actually the thing that we need to do so that people can have access to care. An identifiable source of primary care, appropriate referral to specialists, what they call a patient-centered home. I keep messing this thing up, and I'm so sorry. I'm just clicking and it does, but I know what it says. Give the patient identifiable source of primary care, and then apply evidence-based medicine. It's up there now?
Yeah.
Yeah. I think I'll do the arrow because the clicker is what's doing me off. Identifiable primary source of care in patient-centered home. What we've been doing in New Orleans, if you look at the citation, it's 1995. My wife, who didn't come today, is a PhD in nursing, and for decades we've had the Healthy Heart Community Prevention Project. And our idea was, don't wait for the person to come in for the magic doctor's visit, to go out to the community. And we do a combination of community lectures, health screenings, flu NOLA, we embrace immunization in the community, diabetes, education. We think an educated patient will not allow the clinician to say, Ms. Brown, your blood pressure is a little high. An educated patient will say, what was my number? Ms. Brown, you have a little kidney disease. What is my glomerular filtration rate? What's my GFR? And patients, especially with physicians, more than nurse practitioners and advanced practice nurses, but especially physicians, sometimes don't like that. They don't like a patient question. I'm the opposite. I think the patient should know their numbers. And we also think vaccination the same reason people die from cardiovascular disease, they die from infectious disease. It's a protective shield for the families in our community. Here's one of the studies we did. It's been published. We gave patients blood pressure devices, and then we didn't give them a smartphone. Smartphones are omnipresent. We gave them a program where we could text, and they could text the blood pressures back to us. In fact, the blood pressures would come back automatically, and then we would text messages back to the patient. It's called Text My BP NOLA. It was a pilot study. The device that we gave them was a validated home blood pressure device. We didn't give them a smartphone, but we gave them the app. And what we saw in this real population, if you look at the patients, small sample size, this was a pilot, BMI 34, 64% female, 90% non-Hispanic Black, 25% diabetes, 72% obesity. So these were real patients. This wasn't, the Upper East Side. Blood pressures reduced. Not much change in diastolic, but systolic is the main predictor in older persons. Another thing we're doing in New Orleans is a large NIH grant, multi-million dollars. It's called CHERISH. It's one of those tortured acronyms, church-based health interventions to eliminate racial inequities in cardiovascular health. And what we do is we go into the community with my nurse practitioners and community health nurses to see if you can treat patients outside the clinic environment to eliminate these disparities. We're already over 800 patients, 35 churches. We use medications because the nurse practitioners have prescriptive authority for diabetes, high cholesterol, and hypertension. We also use community health workers. Community health worker is a person who doesn't have a license. It's a member of the community who's trained on how to do blood pressure and educate patients on nutrition, exercise, adherence. And we want to see whether or not we can make a difference. It's going to be a hard lift. We're in the process of doing that right now. It's one of the major interventions. All right, what about the future? 3 minutes with the future. First of all, nobody knows. In the black are some things that are being worked on. There's a natural natriuretic peptide that's an injectable. In the purple, endothelin receptor, that's aprocitentan, that has been approved. In the black is an angiotensin interfering agent. It's zilebesiran, what you inject it 3 months and then every 6 months. Similar to inclisiran for LDL, this is used for blood pressure. It turns off angiotensinogen. Aldosterone synthase inhibitors. There's one called Bactristat. There's another one, Rondostat. They're going to be coming out maybe late this year. In the red are things which are not antihypertensive agents, but may have benefits. There's a non-steroidal minimum carb receptor antagonist, Ferdinand. The RNA that we use for heart failure was first being studied as an antihypertensive. It has an ARB in it, a neprilyzing inhibitor. SGLT2s, used first for diabetes, now for CKD, heart failure, also have a blood pressure effect, and the GLP-1s. This is a cartoon that shows where these agents work. I'm not going to spend a lot of time because I would like to have at least 5 minutes where we can have some discussion. Here's the non-steroidal that works the same area where spironolactone works, but has been shown to be effective for HFpEF and for CKD. Here's the zilebesiran. It's an siRNA. It silences angiotensinogen, the first step in the renin-angiotensin system. Here's the aldosterone synthase inhibitors. They work similar to spironolactone and piridoxine, but don't have the off-target components of them. They seem to be very effective. They're oral agents. This is aprocitentan. It works in a unique manner by addressing endothelin. So they're endothelin antagonists. SGLTs, GLP-1s also have blood pressure effects, not as antihypertensive agents, but related to the SGLT2, the osmotic diuresis, natriuresis, the GLP-1, the weight loss. Renal nerve denervation, we give it a 2B, meaning you may want to consider it. The problem is we don't know who's going to respond. Some people get a very good 7 to 8 millimeter systolic reduction. Some people don't. 2 types are approved, and 1 is being worked on. What about AI? I don't think the computer is going to be able to control cardiovascular. We're smarter than computers. What computers will do, this is a paper that we just published in the American Journal of Preventive Cardiology. These are some of my students, residents, and 1 fellow. What the AI is going to do is allow us to get a large degree of information and then go through machine learning, and hopefully having all of this information will lead to undetected cardiovascular disease, prediction of disease, and personalizing medicine. But I really don't think that that's going to be the solution. The solution, I think, is going to be addressing those social determinants, building into our care models, out-of-office blood pressure, social workers, nutritional consultation, access, coverage for medications and interventions, therapeutic lifestyle changes, combination therapy, and out-of-office blood pressure monitoring. The magic 15-minute visit 99214 is not going to get it for a condition that's so omnipresent. Also, team-based care. It's not just us as physicians. I work very closely with advanced practice nurses, pharmacists. This cartoon is from the AOA magazine, and it shows what we do in real clinical practice. Sometimes we're treating the computer and the patient feels like a bystander. What I suggest is a real patient who allows me to use this picture. Limit the amount of information, slow down, don't show how smart you are using that tortured fact-based language that we use as physicians. Use pictures and models to explain. The show me technique, where you ask the patient, do you understand what I just said? Can you tell me? And encourage patients to ask questions. I know that sounds frightening, but studies have shown if you open that door, the patient is more engaged, and it only adds a few minutes to the visit. All right, last slide. Hopefully I've convinced you that targeted interventions are needed to identify and eliminate these disparities. It's not just a moral issue, it's a practical imperative based on race, ethnicity, sex, gender, geography, where people live, work, play, socioeconomic status, ability, or disability. If we don't give a leg up for the people who need most care, we won't be doing the right thing. We won't be able to change that paradigm where we spend more per dollar in the United States, where we have overall the shortest life expectancies. Thank you very much.
Thank you so much, Dr. Ferdinand. That was a master class in hypertension, how to address, how to treat it. Thank you for coming. We really enjoyed it. So I'll start with the first question. We discussed briefly yesterday about ambulatory blood pressure monitoring. Is it feasible? Is it cost effective? What are your thoughts?
Yeah, and you know, it's interesting. I woke up this morning just to show you I wasn't wasting time in our conversation. I sent you some papers, and then my great friend Carlos, who I've been knowing for decades, sent me a paper that he's been working on. It does appear to be cost effective. NYU utilizes a lot of systolic blood pressure monitoring using the devices. And the home blood pressure devices, even if you're not doing ambulatory, appears to be cost effective. Now, the problem is reimbursement. It's reimbursed by Medicare and some insurances for white coat hypertension. You can also do it for orthostatic hypotension. But beyond that, it sometimes gets a little tricky. But it has been shown to be effective and cost effective. And it's a 1A out of office monitoring. We said ABPM or home blood pressure because we didn't want to box clinicians in that they had to get ABPM. That's why we said the R, but it's a 1A.
And the cuffless?
Mm-hmm.
The cuffless?
Oh, that's class 3. I drove that one home. There's a scientific statement, and I sent you that this morning. The problem is that, for instance, the watch, it really doesn't measure the blood pressure. It uses plethysmography to see the changes in the waveform. There may be some difficulties depending on skin color, activity level, et cetera. And it doesn't give you the same nuance of the blood pressure number. That's what the studies were based on, getting the blood pressure less than 130 or ideally less than 120. The watch is not going to tell you that.
Thank you very much. Any questions from the audience? Carlos? Mario?
Okay. Okay, three quick questions.
So fair. Fun.
I'm so glad that you spoke about equity and disparities. So important. Do you think the guidelines should be doing more to include some of that content in the document? Because I know the 2018 guidelines had a section for treatment in special populations.
Yeah.
That wasn't in the new version. And I guess the second quick question is about hypertensive urgency versus emergency. I mean, I understand, I totally concur with the change, but part of the focus on that severe hypertension is to prevent it to going to emergency. So treating it and addressing it and focusing on it promptly. And the third thing is about alpha blockers. I noticed you didn't mention it for resistant hypertension as a last agent, like the doxazosin in some resistant hypertension.
He's trying to see how good my memory is in my old age. Well, first of all, yes, we don't explicitly talk about special populations. And I worked with the guidelines when NIH had NHLBI, and I was chair of JNC6 many years ago. And we had the special populations, we dragged it along. The American Heart Association felt a little sheepish about that. What I say is that if you apply the evidence as best you can to all patients, regardless of race, ethnicity, socioeconomic status, then we're doing the right thing. The nuance that Black patients need a diuretic or calcium blocker, really when you use combination therapy, if you use an ACE diuretic or amlodipine, A or B, those combinations, it ameliorates differences across populations. So that's why we didn't put a lot of emphasis on that. But I do agree that doesn't mean it's not important. In terms of the alpha blocker, I'll go to the last one. The alpha blockers, there was a study that actually looked at doxazosin versus other agents, including spironolactone. It's just not as good. And it doesn't have as long a half-life. Doxazosin does not have as long a half-life as does spironolactone. So if the person really needs that third agent, I would say spironolactone. If it's a middle-aged older man, he's kind of worried about, quote, my nature, then you would consider pirlinone as generic, but it's not easily as available. Give me the second one again. Got three.
The focus on severe hypertension before it becomes emergency.
Well, we looked at the data. There was actually a study from northern Italy where they did watch those patients, reinstitute oral medicines, and send them home, and they did just as well. And in fact, because you're an experienced clinician, sometimes when we did do the parental and the PRN, the patients would get acute renal failure, hypotension. Some of them would really get into a lot of difficulty. Much of it's related to adherence. You give them the home medicines, the blood pressure drops. It's related to pain. It's related to inappropriate technique. There's a lot of things goes on, both in the clinical setting, emergency room, and in the hospital. We just took urgency off. It's not there anymore. Mario?
So I have about 10 questions, which means we're going to have to invite you back here, unfortunately. But anyway, trying to figure out the one that I think to me is more puzzling. So the guidelines obviously enforce a value across the entire population for targeting initiation of therapy, but population is aging. The GFR by definition falls with age.
Correct.
Systolic hypertension is more prevalent in the elderly.
Correct.
Calcium metabolism is different.
Correct.
Risk of fall is greater.
Correct.
Do we have permissive range for certain age?
If you can recall, we started a little bit late, so I had to move fast. I said institutionalized are patients who have the complications. So if you have complications, of course, you use the choice. But if you look at SPRINT, 9,361 patients, in the forest plot where they do subgroup analysis, they cut it 75 or above. 75 or above did just as good in terms of cardiovascular events and overall mortality. Plus the STEP trial, which I had the little boxes, I went through the Chinese studies, those were patients who were 60 and above, and they did just as well. So if the person is ambulatory, if they're doing okay, again with caution, older persons do just as well with intensive blood pressure reduction, and it appears to decrease cognitive dysfunction, dementia. Dr. Alzheimer's in the early 1900s described a woman who was mentally disturbed and did an autopsy, and she had these plaques in her brain. That was Alzheimer's. We now use it as a garbage can. A lot of these patients have small vessel disease from uncontrolled hypertension and lipids. I think as much as 40 to 50%. They're not Alzheimer's. So I think older persons should have their blood pressures intensively controlled unless they're institutionalized or they're having complications. And even orthostatic hypotension, because the baroreceptor is overstimulated, and it's in our guideline that even with orthostatic hypotension, if you control blood pressure, you can control orthostatic hypotension. It's kind of counterintuitive, but the data seems to indicate that.
Do you use cystatin C in these elderly patients?
We use a lot of cystatin C. In my clinic, we do cystatin C, and we were doing urine albumin creatinine ratios way before the blood pressure guidelines. Cystatin C uses all the cells in the body, whereas creatinine is muscle. So especially in patients who have large body size, and it may have explained some of the discordance in people of African descent who may be bigger, it will show that the creatinine is a little higher, so the GFR is a little lower, but they may not have kidney disease. If you do cystatin C, which is all the cells of the body, cystatin C is normal, no urine albumin creatinine ratio of 30 above, they don't have CKD, even if the GFR is a little down. Did I lose anybody on that? So cystatin C is better, and we do cystatin C in everybody.
Last question, Mike.
First of all, thank you for the talk, your work, and on the guidelines in the community as well. I'm curious your thoughts on getting patients on the right agents versus just making sure that number is where it's got to be. We get a lot of patients for consults for maybe something else, and they're on, doxazosine and diltiazem, but their number's great. Doc, I've been on it for 10 years, and I don't want to make changes. So
the numbers may not be great if they do out-of-office blood pressure.
Let's assume that is the case. What is your?
I think the most powerful predictor is the number. The medications don't have as much of an effect. One of the reasons we don't have beta blockers, especially the short-acting beta blockers, they're cosmetic, slow the heart rate, lower the blood pressure, and then it goes back up. Same with the alpha blocker. So I would do out-of-office blood pressures. We can get home blood pressure units paid for by some insurances. You have to check with your locale and what insurance they have. ABPM, some people will cover. If you just say white coat hypertension, orthostatic, give them a diagnosis because that's all the code wants. Then that will really tell you whether that person is quote controlled. Now, some differences. If they have heart failure with reduced ejection fraction or preserved ejection fraction, there's certain evidence-based outcomes with that. If they have CKD, it's in the guidelines 1A, ACE or ARB, and we give equal poise to it. I think the ARBs are maybe a little bit better because that 10% cough can be really disruptive and the angioedema can be really, really profound. And ACE inhibitors are not better in that condition. So I think the numbers most important, but I also want to make sure that the numbers are real. And I would like to look at target organ damage and consider what to use secondary.
Thank you very much. So
all right.
We can end with that. We
yes,
really
sir.
appreciate your visit.
It's my pleasure. I had a great time.
Congratulations on the amazing work.